صباح الخير. النهارده هنتكلم عن evaluation and management of kidney transplantation candidates KDIGO 2020 recommendations. These guidelines address general candidacy issues such as access to transplantation, patient demographic and health status factors, immunological and psychological assessment, the role of various risk factors, and comorbid conditions governing the individual suitability for transplantation, such as adherence, tobacco use, diabetes, obesity, preoperative issues, cause of kidney failure, infections, malignancy, pulmonary disease, cardiac and peripheral arterial disease, neurologic disorders, gastrointestinal and liver disease, hematologic disease, bone and mineral disorders. أول حاجة هنبدأ بالaccess to transplantation. All patients with chronic kidney disease stage 4 to 5 who are expected to reach end-stage kidney disease should be informed of, educated about, and considered for kidney transplantation. Refer potential kidney transplant candidates for evaluation at least 6 to 12 months before anticipated dialysis initiation to facilitate identification, workup of living donor, and the plan for possible preemptive transplantation. As a preemptive transplantation with living kidney donor is the preferred treatment for transplant-eligible CKD patients. As regard age, don't exclude patients from kidney transplantation because of age alone, but rather consider the context of other comorbidities, including frailty that may impact outcome when deciding about suitability for kidney transplantation. Pediatric issues: perform neurocognitive assessment in pediatric candidates who are experienced end-stage kidney disease before age of 5 years, and an academic assessment of those who are experiencing difficulties at school. Psychological assessment. Psychological assessment should be performed in all candidates by healthcare professionals experienced in psychological aspects of kidney transplantation. Pre-transplant counseling and service should be offered to candidates with diagnosable psychiatric, psychological conditions, substance use disorders, or non-adherence. Assess adherence. As regard adherence, assess adherence and adherence barrier pre-transplantation. Appropriate adherence-based education, counseling, pre-transplant and post-transplant surveillance should be provided. Candidates with history of non-adherence from kidney transplantation should not be excluded, except for those with ongoing health compromising non-adherent behavior despite education counseling. Tobacco use. Assess candidates for past and present use of tobacco products. All candidates should avoid tobacco products before and indefinitely after transplantation. CT chest for current or former heavy tobacco users, more than 30 packs per year, to screen for occult lung cancer is suggested, and chest X-ray for other candidates. Surgical issues including obesity, candidate assessment of body habitus, frailty, and medical conditions that could inhibit wound healing should be performed. Candidates should not be excluded from transplantation because of obesity only. Candidates should not be excluded because of their need for anticoagulation, antiplatelet therapy, or history of heparin-induced thrombocytopenia. Assess vascular anatomy and patency for patients with significant peripheral arterial disease, pre or transplant procedures, venous dialysis catheters, pelvic surgery, or deep venous thrombosis. Evaluate native kidney size in patients with polycystic kidney disease. Staged or simultaneous native nephrectomy and the transplantation may be considered for candidates with painful, recurrently infected, potentially malignant polycystic kidney, or if the patient has insufficient room for transplant. Diabetes. Candidates with diabetes mellitus type 1 or type 2 should not be excluded from kidney transplantation. Testing for abnormal glucose metabolism by oral glucose tolerance test is suggested in candidates who are not known to have diabetes. Cause of end-stage kidney disease, candidates should be determined where possible to inform risk and management after kidney transplantation. So candidates with primary FSGS, membranous nephropathy, IgA nephropathy, IgA vasculitis, immune complex mediated membranoproliferative glomerulonephritis, C3 nephropathy, lupus nephritis, antiphospholipid syndrome, ANCA-associated vasculitis, anti-GBM disease, HUS, atypical HUS, fibrillary or immune tactoid glomerulonephritis, correctable hyperoxaluria, those with cystinosis, Fabry's disease, sickle cell disease, sarcoidosis, Alport syndrome, systemic sclerosis, AA amyloidosis, with no severe extrarenal disease should not be excluded from transplantation. However, the risk of recurrence should be considered and discussed with the candidate. Candidates with multiple myeloma, light chain deposition disease, heavy chain deposition disease, light and heavy chain deposition disease, AL amyloidosis should be excluded from kidney transplantation unless they have received potentially curative treatment regimen and are in stable remission. As regards infections, delay kidney transplantation until active infection, whether bacterial, viral, fungal, parasitic, are treated. But asymptomatic colonization with bacterial, viral, parasitic, fungal organism should not preclude the transplantation. Screen all candidates for infections including HIV, hepatitis B, hepatitis C, cytomegalovirus, Epstein virus, varicella zoster, herpes simplex, measles, mumps, human T-cell lymphotropic virus, and syphilis. But screening for hepatitis D virus, strongyloides, Chagas disease, tuberculosis, and malaria may be considered in endemic areas. Vaccination series recommended for the general and immune-compromised local population should be completed prior to kidney transplantation. Levatin-weighted vaccines should be completed at least 4 weeks prior to transplantation. Vaccination can be considered for candidates who, due to age, direct exposure, residence, or travel to endemic areas, are at increased risk for specific disease, such as rabies, tick-borne meningoencephalitis, Japanese encephalitis, meningococcus, salmonella, typhi, and yellow fever. Malignancy. All candidates should undergo routine cancer screening as per local guidelines for general population. Candidates at increased risk for renal cell carcinoma, bladder carcinoma, and hepatocellular carcinoma should be screened. Candidates with active malignancy should be excluded from kidney transplantation, except for those with indolent low-grade cancer, such as prostate cancer with Gleason score less than 6, superficial non-melanoma skin cancer, and incidentally detected renal tumor less than 1 centimeter in maximum diameter until remission following potentially curative therapy. Timing of kidney transplantation after potentially curative treatment for cancer is dependent on cancer type and the stage at initial diagnosis. Decisions about transplantation for candidates in remission from cancer should be made collaboratively with oncologists, transplant nephrologists, and patient and their caregivers. Pulmonary disease, pulmonary function testing is recommended in candidates with impaired functional capacity, respiratory symptoms, or known pulmonary disease. All candidates should avoid tobacco products before and indefinitely after transplantation. Patients with irreversible severe obstructive or restrictive lung disease should be excluded from kidney transplantation. In the cardiac diseases, evaluate all candidates for the presence and severity of cardiac disease with history of and physical examination and ECG. Patients with signs and symptoms of active cardiac disease should undergo assessment by cardiologists and be managed according to current local cardiac guidelines prior to further consideration for kidney transplantation. Asymptomatic candidates with, at high risk for coronary artery disease like diabetics or previous coronary artery disease or with poor functional capacity should undergo non-invasive coronary artery disease screening. Asymptomatic candidates who have been on dialysis for at least 2 years or have risk factors for pulmonary hypertension should undergo echocardiography. Cardiac imaging should be performed in patients with systemic amyloidosis to ascertain cardiac involvement and severity. Candidates with uncorrectable symptomatic heart disease, severe coronary artery disease or left ventricular dysfunction, or ejection fraction less than 30%, severe valvular disease should be excluded from kidney transplantation. Candidates who have had myocardial infarction should be assessed by a cardiologist to determine whether further testing is warranted and when they can safely proceed with kidney transplantation. Cardioprotective medications, including aspirin, beta blocker, statins, should be continued during wait listing and at time of transplantation. Peripheral arterial disease, evaluate all candidates for presence and severity of peripheral arterial disease with history and physical examination. Those without clinically apparent peripheral arterial disease but who are at high risk for peripheral arterial disease should undergo non-invasive vascular testing. Candidates with clinically apparent peripheral arterial disease should be seen in the consultation with vascular surgeon. Patients with clinically apparent peripheral arterial disease or abnormal non-invasive testing should undergo contrast CT imaging of abdomen, pelvis to evaluate arterial calcification and improve operative planning. Candidates with non-healing extremity wounds with active infection should delay transplantation until the infection is resolved. Patients with severe aortoiliac disease or distal vascular disease should not be excluded from kidney transplantation, but risk of progression after transplantation should be considered and discussed with the patient. Neurologic diseases assess mental states in candidates with known or suspected cognitive impairment, candidates with non-progressive intellectual, developmental, or cognitive disability should not be excluded from transplantation. Candidates with peripheral neuropathy should not be excluded from kidney transplantation. If such a neuropathy can be attributed due to uremia, urgent access to transplantation may be considered. A suggested waiting time of at least 6 months before kidney transplantation is advised for those who experienced a stroke and 3 months for those with transient ischemic attacks. We don't recommend screening asymptomatic candidates for carotid stenosis. Screening candidates with autosomal dominant polycystic kidney disease for intracranial aneurysm may be warranted only if they have a high risk due to prior history or family history of subarachnoid hemorrhage. Gastrointestinal and liver disease. Evaluate all candidates for presence of gastrointestinal disease, including liver disease with targeted history and physical examination. Candidates with history of peptic ulcer disease, diverticulitis, acute and chronic pancreatitis, asymptomatic cholelithiasis, or inflammatory bowel disease should not be excluded from kidney transplantation. For such candidates, delay kidney transplantation until symptoms have resolved. Screen kidney transplant candidates for liver disease with total bilirubin, ALT, and INR and albumin. In the presence of acute hepatitis of any cause, delay kidney transplantation until resolution and long-term strategy for managing liver disease has been implemented. Candidates with cirrhosis or suspected cirrhosis should be referred to specialists with expertise in combined liver kidney transplantation for evaluation. We recommend screening for hepatocellular carcinoma in candidates with cirrhosis prior to transplantation. Hematological disorders, routinely screen for thrombophilia in candidates is not recommended. Screening for thrombophilia should be limited to those who with experience of venous thromboembolic events, recurrent arteriovenous access thrombosis, non-atherosclerotic arterial thrombosis, or family history of venous thromboembolism to identify candidates at high risk of graft thrombosis. Testing for antiphospholipid antibodies may be warranted in patients with systemic lupus or features of antiphospholipid syndrome. Evaluate transplant suitability of patients with significant cytopenias based on cause and severity in consultation with a hematologist. Candidates with monoclonal gammopathy of undetermined significance or smoldering multiple myeloma should not be excluded from transplantation, but a greater risk for post-transplant lymphoproliferative disease and the transformation to multiple myeloma, respectively, should be considered and discussed with the patient. Patients with leukemia and lymphoma should avoid transplantation until they have received potentially curative therapy, achieved remission, and remained cancer-free for a period to be determined with their hematologist and oncologist. Decisions about kidney transplantation in patients with myelodysplasias, chronic leukemia, and a lymphoma, chronic low-grade lymphoma, or prior history of hematological malignancy should be made after consultation with a hematologist. Bone and mineral metabolism. Measure serum PTH at time of transplantation. Transplantation for patients with severe hyperparathyroidism should be delayed until they have been adequately treated. Immunological assessment. Communicate all sensitizing events or clinical events that can impact panel of reactive antibody to human leukocyte antigen. Perform HLA antibody testing at transplant evaluation at regular intervals prior to transplantation and after sensitizing event or a clinical event that can impact PRA. HLA antibody testing should be performed using solid phase assays, and HLA typing should use molecular methods optimally at all loci. Routine testing for non-HLA or complement binding HLA antibodies is not suggested. Candidates should be informed about their access to transplantation based on blood type and histocompatibility testing results. Thank you.